We are going to move into our next speaker, a parent advocate, and offer a little parent reflection, Rebekah Peterson.
Thank you. 14 years ago, we had a little boy, and he's the little boy there, who was considered incompatible with life. By the time he was 5 months old, he was trached, oxygen dependent, G-tube dependent, ventilator dependent. I did not find out until actually just a few years ago. One of the reasons we got the top of the line home RT was because DME was told that this child's not going to be at home very long. The case will last a couple days, maybe a week. He's going to pass away, but the family really wants him at home. Like I said, I didn't find that out until then. He's obviously more than a few months old here. Erin loved his life. His primary diagnosis was trisomy 18, often grouped with trisomy 13 because they're considered still today in medical literature to be incompatible with life. We were told he probably wouldn't survive birth. However, when he went in for his G-tube surgery, he failed extubation spectacularly. We're talking CO2s of, I don't know what, north of 130, pH of less than 6.9. He was, and that was just within minutes. Got everything settled, found out again later that the ENT was actually prepared to trach him bedside because he didn't know if he could reintubate. Get it all done, I looked at the ENT and I said, we need a trach. And he says, if you want to keep him, he needs a trach. I said, okay, so when we're doing it. Was I clueless? Yes, I was clueless. The only letters after my name at that point in time were M-O-M. Didn't have any idea what I was getting into. ENT took a chance on Erin. At that point in time, 2010, life expectancy for those who did survive birth was 5% at a year. There were some that were trached in the trisomy world. We're not talking about Salt Lake. We're talking the trisomy world. Geneticist that was practicing here is the world's top authority in 18 and 13. And there were some that were trached, usually for some kind of stenosis. I've not been able to find record of another child on a ventilator at that point in time. But Erin was trached. Erin loved his life. He was a nut. Talk about teasing those older brothers you saw in that picture. When he was in grade school, he used a computer, an eye gaze computer, and he'd throw pies at their faces. The next older brother decided he was tired of being pied, so he switched his picture with Erin's. Erin would not throw a pie at his own face. I didn't know this. They told me this from school. He had to touch the screen to move on if his face showed up. I told his older brother, I'm like, stop, you're done. He's throwing them at you. It's not really your face, it's your picture. But he did, he loved his life. And because Erin was trached, and Erin was vent dependent, and Erin went to school, and he traveled on a road trip to Arizona, and he went to soccer games, and he went to ballroom concerts, and he was noted to sometimes have better rhythm than some of the kids on the floor competing by coaches. Other doctors took chances. Other children were trached. A lot of kids with trisomy 18 and 13 now have trachs. Many of them are on ventilators. Many of them go to school. Erin never walked. He felt like he had a gait trainer. The purpose of the gait trainer was so his brothers could zoom him around the house. It was not to put his feet down and walk. But other kids are walking because a doctor took a chance on Erin. Because they listened to me when I said, we need a trach. And when he struggled on his ventilator settings, I refused to go to another hospital that would take us 2 hours away in the middle of winter from all my other kids. And the RTs found settings that would allow him to go home, even if it was just for the few days they thought he was going to have. Today, those children who are born with trisomy 18 and 13, instead of a 5% survival rate, those who receive interventions are somewhere between 30 and 50% chance of reaching a first birthday. Because a doctor was willing to listen to me, we have national, not global because of other medical interests and policies, but we have nationally increased the survival rate of these children and impacted their families. 5% to 30 to 50% reach a first birthday. Now, Erin was a nut. He used that same computer one time to roll his eyes at his principal. She came in, he was taking a test. He hadn't had it very long. So we didn't really know what he did know and what he didn't know. And so he was doing shapes because, actually we were told he was supposed to be a vegetable. So we were doing shapes. He's taking a test on shapes. He'd had the computer for about 2 weeks. She comes in and goes, "Oh, Erin, are you taking a test?" And he rolls his eyes, navigates away from the test, goes to a completely different screen and says, "Test is boring. Teacher is boring." They threw a party, and his brother, who was a junior, who did not like school, was like, "Can I tell my teachers they're boring?" I'm like, no, you cannot. Sorry, not an option. The thing that we learned at primaries, Erin spent a lot of time at primaries. He would get giddy when we pulled up here, especially if he was in an ambulance. He loved people. The PICU was his favorite place. I'd be down in the cafeteria and people say, "Oh, how's Erin doing?" I'm like, "Oh, he's having a party in the PICU." I'm like, "Oh, I'm so sorry." I'm like, no. Erin is having a party in the PICU. He is having a blast. I would like a better place to sleep, but he's having a great time. But I was a member of the team. I was part of rounds. I did participate. When there was a question of whether or not we were going to be giving a transfusion because cardiology felt like it would help, and PICU was like, "We're worried about fluid overload." I remember a very distinct conversation with the PICU attending, and she looks at me and she says, "Do you want a transfusion?" And I said, "I don't know." And she said, "Okay." And so we sat down, the two of us, and set out parameters for when we were going to pull the plug on the transfusion. I was a member of his team. They listened for the need. They listened to Erin, and they listened to me. Because at the end of the day, guys, if you're here as a professional rather than a parent capacity, you go home. Burnout is real. I'm a therapist. It's a real thing. It is also the privilege of a professional because a parent doesn't get to get burned out. We have to figure out how to keep going. We have to keep moving. This is our last family picture with Erin. And my sweet granddaughter's holding his representation in this one. I hope you remember, first of all, I hope you're passionate about your jobs. I really do. But the family needs to be the center. Because when you have a child as a patient, you don't have a child as a patient. You have a family as a patient. You have everybody. We need to be able to see the patient and see the family. We need to see the child. Take a chance. It needs to be a child and family-centered approach with system support. Thank you.
Oh, thank you. Thank you, Rebekah. Yeah, I remember those times down there where you were going to grad school with Erin in the ICU and wondering how you did it all. All right. I would like to welcome our panelists up to the stage here to talk about how to influence system change. So, Dr. Erin Avondet, please come on up. She's a pediatric hospitalist at Primary Children's and a medical director for the Primary Children's Connector Service. Tracy Johnson, the program director for Allies with Families. Calleen Kenney, did I say that right? Calleen? Parent consultant for the Utah Family Voices Family to Family Health Information Center. And Stephanie Stokes, community health manager for Intermountain Healthcare. Welcome. So you've been brought on to talk about influencing systems change, and you've heard from Rebekah, we heard from Dr. Ferguson, steps they've taken to help kind of influence systems in the hospital. So please.
Yeah, and I'm just thrilled to be here and on this panel with so many really smart and really talented people, and I'm kind of wondering, what am I doing as a public health researcher here? But I am just here, and I'm actually hoping to not use slides, and I was really intentional in that because I'm hoping you'll indulge me in a little bit of storytelling. because it has been my role and my pleasure for most of my career to understand how stories change systems. I do have notes though, because I can become a data nerd and geek out and don't want to get too far from my points. And really, how do we use research, right? How do we use research to change those systems and balance studies with stories? And I actually am formulating a study from today's conference based on the number of people who start in hospice and end up here, because that's actually where my story starts. I was part of a hospice organization in Maryland. This was my first job out of undergrad. I was very, very excited. And the position that I was asked to really lead and be a part of came from storytelling. The hospice organization had found that particularly women or people who identified as female on their deathbeds were disclosing really tragic losses, miscarriages, stillbirths, early experiences that their families did not know about. It was a time in our country and in our nation where that type of loss, that type of grief was meant to be handled in silence and in isolation. It was normalized in a different way. And so I was brought on with an expertise in kind of women's health and perinatal loss to change systems, to create a perinatal loss hospice program, a pediatric hospice program, and learned very quickly. One, I had an amazing mentor that told me I'm a little confrontational for counseling. And two, I was just so disappointed in the system and how the system wasn't serving people, right? We were working with ultrasound. We were working with amazing clinicians who cared so much and were stuck in a system. I was working with patients who felt like they weren't being served by the system. So I had a bit of a career pivot into how can we do this better? And I actually ended up pursuing a degree in public health. And why I did that was because public health is literally designed to treat the community. It's designed to understand how do we take systems and influence them and make the health an easier choice. And for over a decade, I had the opportunity to work within Intermountain Healthcare's Office of Strategy. I was part of an internal research consulting team that had one job, which was to help leaders ask better questions and help leaders make sure that patients were at the core of their questions. Healthcare leaders are looking at a lot of data all the time, and they sometimes forget, bless their heart, they sometimes forget that they're treating patients, right? I think we all forget that sometimes in our job. And so I had this really fun opportunity to put patients at the center of every research question. And I'm going to introduce a couple of frameworks because that work was not easy. But there are some frameworks and there's technical terms I'm going to share with you that I'm happy to send by email if you prefer to learn that way. But I was able to work within grounded theory research and community-based participatory research, or CBPR, as we like to call it. And why that framework really led to success is, one, it's based on collaboration. It's a research framework that allows us to put people at the heart of the research design, allows us to include culture and community and identity in our research, all with the specific goal. It's not a randomized control trial. It's not a clinical trial, but the goal is to design solutions and understand solutions that are actually going to improve health equity and address disparities and things like that. And now maybe some of you are hearing this and thinking about this mixed methods research. This sounds a little squishy. Well, you know what? Humans are squishy. So I think that allowing us to do research in a way that understands and prioritizes the human experience is how we're going to bring change to systems. And so I did this work through communities, through our community health needs assessments, worked with our Institute for Patient and Family-Centered Care through a lot of that research, and I'm happy to continue to share that experience and really how can you be involved in systems change and bringing that change not only to your own life, but to broader systems that we all have to work and operate in. And so now you may have heard my job title and wonder what I'm doing as the community health manager for Primary Children's, right? It is a little bit, I recently had a career transition, and the opportunity for me to work with children really came from two things, because I love research, and I'm happy to nerd out with any of those other data nerds out there. But youth are not represented in research well. I was continually frustrated by being asked to aggregate data by race, ethnicity, zip code, age, sex, sexual orientation, gender identity, all these aggregates. And yet we rarely pause to ask, are you a parent? Do you have children in your home? And heaven forbid, we ask youth to speak for themselves. So I found a home in Primary Children's Hospital that really embraces this type of research, embraces this opportunity to bring change not only to our patients, but to the community at large. I was also very motivated because I became a primary children's parent with my younger child, and being able to be part of an organization that I saw put the family first multiple times. It's not perfect, and I want to acknowledge that. But it was really special for me to have that career change, which is very new, and I'm happy to kind of talk about both worlds. But the things that I hope that you hear and learn today, and I'm sure we're going to have similar themes on this panel, is why research, and how do you get activated in changing the system? And the first thing I want to say is be brave. These are vulnerable stories, and they're very emotional stories. But when I can bring a story to a leader, it changes their mind. It changes their opinion. The second one is please take the survey. I know you get a lot of surveys in healthcare, but oh my goodness, we use those surveys all the time. And so please take the survey. And my final recommendation is find allies and champions in this work. It takes time to change systems, and it is so frustratingly slow. But to be around other people that are fighting the same cause with you can really help with that burnout.
Yeah, thank you.
I'm also a data nerd, so let's talk later. Love it. Well, my name is Erin Avondet. I'm one of the hospitalists that works over at Primary Children's, and unfortunately, when they mentioned Riverton, I wanted to cry because Riverton's closed, and I miss it every day, but now at Lehigh Hospital. So the Lehigh campus is now open, so I work at both campuses. But I also have a very unique privilege to work a little bit in the outpatient world, which a lot of my colleagues do not have that. So I work as the medical director for a program called the Connector Service. It's funded by the Foundation Free to Families, which is amazing, but it's for medically complex children who have 3 or more body system involvements, who also have social, political determinants of health that are affecting their access to care. So I get to see a lot of the care continuum. And one of the things that I think is really interesting as a hospitalist is my role feels very narrow in a lot of ways. And I think, sometimes we feel like we're at the bottom of the food chain. We're just here taking care of kids every single day in, day out. How are we going to impact change? And sometimes that's something that just kind of falls to the wayside, right? Impacting systems, impacting all of these systems are so much bigger than we are, right? It's so far above my pay grade that I just don't even know where to start sometimes. But one thing for me as a hospitalist is because I see the fallout so frequently from systems that are ineffective, from systems that are causing families, physicians, nurses, staff, all sorts of people, it's causing them a lot of pain and a lot of frustration when it comes to caring for families, right? This downstream effect of these upstream things. That sometimes you can feel a little bit helpless. I personally, and Tony laughs, I laugh about this too. I personally have always approached it from, if you guys have ever seen The Avengers, the Hulk says, my secret is that I'm always angry. And that's how I feel all the time. I'm always angry, right? But anger doesn't get you anywhere when you can't turn that into action. And so sometimes it's seeing those downstream things where it's just like one problem after another, being able to focus on those things. When you have people that you're working with, when you have teams, when you have people that are also invested in the causes that you are, then you can impact systems changes. So I do spend a lot of time up at the Capitol during the legislative session, talking specifically about children's health, right? So Medicaid is one of my big passions, and other children's health issues as well. But I feel very strongly about, funding Medicaid and funding different parts of Medicaid. And so that's something where it's like you have expertise as healthcare providers, as people who are in the healthcare system, that, let's be honest, the legislators, they don't know anything, okay? They don't know. They need people like us to come up there and speak with them about these things. And there are ways for you to find, whether it's through research or going to the Capitol, systems changes in the hospital or whatever it may be, wherever you are, you have a voice, you have that power. It kind of feels trite to say that, but it's very true, especially when you do it with other people. So if you have that organizing power can go a really long way. And so it's something that I, have tried to engender in my teams, is that, hey, this work that we do, the advocacy that we're capable of is so important. So I think if I could tell you like two things to take away, it's like, if you're always angry, turn that anger into something. Like if you're like me, where I'm just constantly finding things to be furious about, you can turn that anger into something productive, right? Otherwise it just eats you from the inside out. The other thing is find your people that you can organize with. And that may be a theme here that you may find, but that's just something that I think when you want to have systems change, doing it alone is hard. It's not impossible, but it's definitely very, very difficult to do it alone. So if you have coalitions, that is something, community, coalition, wherever you find that, that's where the system changes can definitely come, whether that's in a hospital or through the legislature or whatever it is.
So not just Hulk, but Smart Hulk.
Smart Hulk.
Hulk with his glasses.
It's right before he turns into just Smash Hulk.
Yeah. Thank you, Erin.
I'm sure glad that I'm here today. I was just going to come and talk, but I'm sure glad I got to hear from everybody. So I am Tracy Johnson. I'm really not with Allies with Families anymore. I do live in Southwest Utah. I live in a little tiny town called Tropic, Utah. Most important about me is I'm the mother of 7 children. Two of my children have significant mental health issues, and one has intellectual disability. He has Down syndrome and some mental health issues. And I currently work with the division of who do I work for? Regional support of, I get nervous. Community care and regional supports under the Division of Health. And my role is to, I'm called the lead family coordinator, to coordinate with families who are in our state system in the in family health. And we provide intense care coordination. So that is care for Utah's most complex children who are usually involved in multiple systems. They usually have DCFS, JJS, mental health, disabilities. They have a lot of stuff going on. So I began this journey as, so I was a child from the system in foster care, residential treatment, many facilities. I had, at 15, I got pregnant. I had 3 kids before I was 19. I lived on the streets. I left Southwest Utah and came to Salt Lake because there were better drugs. I don't know. Anyway, lived on the street, walked to it was LDS Hospital at the time, to have my first baby at 15, and they wouldn't let me walk away. They made me take a taxi, which took all my money to get there, and then I couldn't eat for weeks, right? And nobody asked those questions. All of those things happened. So anyway, years down the road, about 32 years ago now, I got sober. I had 4 little children. I wanted a different life for these kids. I finally was in a supportive relationship, had 3 more kids and my son with Down syndrome. One of the local interagency councils, or FACT, Families and Communities Together, I don't know if you know some of that, invited me to be on a parent panel, as a part of a parent advisory council. And talk to agencies about how the system affected us as a family and things that had happened to my children. We'd have been involved in all the agencies, and then we got to be part of a research project called the Frontiers Project. It was this original system of care project. But I was the Hulk, and I thought that they said, we want to hear from you about how this is working for you. And the problem was I was angry, and I told them. And then all of a sudden, all of my therapists and the caseworkers, the people I was working with were at the table. And I just said really bad things about all the stuff they did. So they should have warned me. So a takeaway about that is, as you involve parents and you ask them for what you need from them, please prepare them and help give them a mentor and put them in safe places, because it took me a long time to recover from some of those mistakes that I made. But the good part of that was they taught me to be an advocate for my family. There were a lot of things being really angry that I wanted to change, because I really wanted a different life for my family, for my kids. I didn't want them to be back in that system. And so I was able to I was a parent advocate. I decided to start a nonprofit because we had come to we actually went to University of Utah, but my son had heart surgery at Primary Children's. Anyway, he, when we went home, and then my daughter went to mental health treatment up here, we went home and there was nothing and there was nobody. There's got to be some people here. So I started looking for my people. I ended up starting a nonprofit in partnership with the mental health treatment people. And and we partnered together on how to make sure that parents had a peer with them, somebody who had, we call it lived experience, or had a shared experience, to be able to guide them through this really complicated system. So I know we've heard this talked about, but peer support saved our family's life. And the people who believed in the parent-centered approach saved our family's life. And it was really pivotal for our experience. So I want to just talk for a minute about some of the barriers families face when they come into treatment. And then I want to talk about opportunities for us to work together to help make these systems better. So there are siloed systems, right? So one of my first experiences in advocacy was I came home with my son with Down syndrome, and I have these other daughters who have lots of challenges too, but Down syndrome like pushed me over the edge, right? Because he had medical issues too. So we had people coming into our home. I had 5 case manager type people, and he wasn't even in school yet. And the system told me that was not true. They didn't do that to families. And so because who I am, I called the director of the Department of Human Services, and I said, could we meet? I got to show you some stuff, right? So I set my plans out, and I said, this is our schedule of our family, and here are all my plans. And he's like less than 2 years old, right? And so he's 1. I have these other 6 children too, right? And these are all the things that we're required to do, all this therapy appointments and things. And did I tell you that I live in Tropic, and the closest mental health center or hospital or medical facility is 45 minutes away? It's an hour and a half to Walmart. Anyway, so lots of barriers, right? So those siloed systems, not talking to one another. The one thing that I continue to run into is language and communication problems. I think we've talked a lot about this, is all systems have their own language, and they don't know how, and they use the same words in different contexts, and it's really, really confusing. And then if you're, it's often really, so I find a lot of times when I was doing peer support, I was the translator. So I'd listen to the parents, hear what they say, translate it, and then tell it to the professionals, and then back and forth, right? So we don't understand that language. Every system has a different language, and they don't have time or interest to talk about the entire story, and we get really, as families, we get really, we add a lot of detail and things that don't matter, and we don't really get to the point. So I think that is really hard for people to listen to. So we're often have different beliefs or direction about what we think will work. We get angry and frustrated. There's not this point person. We don't always feel listened to. The system is complicated, and we don't understand where we're going or what's available in our community. So those are some of the barriers that parents can face. Oh, okay. So just look for opportunities. No, thank you. I should have been watching. So opportunities, just what these guys said, build relationships, support families to be able to tell their story. It's really impactful, and build those partnerships so that together you can make the changes that are going to be better for the people you work with, families you work with.
I also have some notes because I'm super nervous and I don't even know where I'm going. But I'm also super geeky, but about like family care systems and stuff. Like professionals I've been doing this for 20 years. I have a 26-year-old daughter. And she has, in those years, she's received multiple diagnoses. I was going to try and like count them all a minute ago. I'm like, should we map out where this went from 16 months to 26 years old? Because some of her more severe diagnoses actually have only happened in like the past 5 or 6 years. And that's just because like science and medical stuff, like she got a genetic diagnosis. She actually has a 22q13 deletion, and hers is because, again, science is insane. Like we know it's exactly at 13.3, so she's missing her entire strength 3 gene, which maybe you can tell me. Apparently it's very important for development, and she doesn't have that. So, but her initial diagnosis was just developmental delay. I didn't know what that meant. I'm like, yeah, she's not talking. Obviously there's a delay, but worse words were used than that in relaying that information to us to get me to understand that. And then along the way, it was autism and the rest of the alphabet soup, we call it ADHD, OCD, ADHD, all the things. And then later into her teen years, it was the mental health stuff. And dual diagnosis is a pain because, again, she doesn't like not talk, but you couldn't understand her. You wouldn't be able to get her to answer a question, So those things are very difficult. Like we can't do that in traditional therapy and stuff, but she still receives those diagnoses. She has, bipolar. She has treatment-resistant mood disorders. So yeah, that's all fun. It's all fun. But 20 years ago, I was just in, I guess now it's been like 24 years, in the right place at the right time. I am a very highly networked and connected parent now, and we still don't always, have that golden ticket for everything. But I didn't do it alone. I definitely had a hand to hold the whole time. And now I'm fortunate enough to be able to work for an organization where I do get to pay that forward and I do get to help other families. So I'm here today and I want to talk to you guys about Utah Family Voices, which is a project within Utah Parent Center. If you've heard of the Utah Parent Center, you might traditionally think of like the school supports, which are, again, super important. We talked about talked about that earlier. But the neatest thing about our center is all of our staff are parents, caregivers, siblings, or individuals with children and youth with special health care needs. So we all have that lived experience at some level with some disability. And the important thing about that is that, again, we are the state's designated affiliate of those national programs. So we can receive funding from maternal and child health. And we sometimes have to pick up kids, not today, but forget to turn off all the alarms. I have like 17 of them. I think that's the last one here today. But these networks were built for this, like to help teach parents and to mentor them into advocating and to help assist families in navigating and accessing healthcare specifically. That's what Utah Family Voices does. That's what Family Voices is for. And to find those family support services and to make sure that those services are, again, family-centered and culturally appropriate. We do that by trying to provide accurate and research-based information. So sometimes I say I'm just a professional Googler, but in that I have Googled Social Security so many times that I know what link to send you when you need to do this. You know, even our website is so full of amazing information, but it's a rabbit hole, man. Like, so if you want something, like, you need to call me and ask me, and I will send you the link for that page. It's way easier, I promise. We also educate about a medical home. So in Utah, we only have one official home program, but we want to help families as well as providers learn what that looks like and also advocate for that. We've helped develop a care notebook. So again, as we're talking about these journals and these amazing things to help families either advocate for themselves in the moment in the system or prepare their youth to do that on their own and help learn how to advocate for themselves. We have all these really cool pages within a care notebook that we can also help with. So some of them are just like basic family information, your address, but some of them go into again, what types of food I'm going to eat? What are my safe foods? What does that look like? Do you have to be fed? Do I need to have, what kind of preparation does it take for me to do certain things independently? But also, again, just charts for baseline things. Again, mood things, different catheter changes, all kinds of stuff, seizure logs, everything that they can keep, either visually or just as an idea to get you going for other kinds of electronic tracking and stuff. We also do a lot of, again, information and education workshops for families as well as professionals. Everything is free. Most of our stuff, thanks COVID, is available virtually, so we can serve so many more populations now. We do have services across the entire state, but we are kind of more housed in Murray, so that does hurt, doesn't help outside that. In the school systems, we have dedicated district consultants. Again, these are parents that have gone through the IEP. They're actually trained. We send them to education law conferences to help families, and they're the ones that will sit next to you and help you advocate for that. I can help with, again, medical and health resources, as well as those systems things, DSPD, MCCW. I can translate those acronyms for families. Again, we can be that person as well. But also just helping. But I'm not going to fill that application out for a family. I'm going to sit next to you and going to help you learn how to do that because, again, I want you to go out and also know how to do that in other systems. And most of these applications, parents get so overwhelmed because there's just so much to do that they're like, this is too much, it's too hard, this is so complicated. When I sit down with them, it looks more like, what's your name? Put that on there. What's your address? Put that on there. I will wait all day, you know what I mean? But again, I don't have that information. I'm not an assister. So again, like a system like Social Security, you have to have somebody that signs that says, I helped this person fill that out. I'm not gonna do that. But I will sit there with you and just be your support person that said, I've been that mom that, yes, I was a single parent, I've been homeless, I've been through DCFS, I've been through all the systems. And if I can do this, I promise you can do this. I promise, we can do this together. But most of it really is not bad. So just know that we're here. We can, and again, those are available for professionals as well.
Wow, thank you. Questions? Thoughts? So yes.
I could just talk about, how do you refer people to your program?
So we have a main line. We have administrators that answer phones in English and in Spanish. We also have capabilities to translate into other languages as well with outside contracted providers. I have flyers back there, but yeah, you just call into our main center and they will put, it sounds really bad, but I promise it's not, to an appropriate call log. So again, if it's a school related issue for Canyon School District, they will give that to Elise Merrill. If it's a health and medical resource question or a support question, then they'll put it on the Utah Family Voices log, and one of 4 of us. We also have a Spanish-speaking consultant on Family Voices that will get back to somebody as soon as possible. So yeah, we initiate those just in phone consultations, but we can meet in person as well in a lot of areas.
Tracy, what is the name of the nonprofit that you?
So it was I started New Frontiers for Families, and we did a lot of projects with the in my area with the FLDS communities and the Native American populations down there on the border, kind of where I live. We started it kind of that way, and it was all about just parent support and navigating the system. We merged with Allies with Families, and then they recently have gone out of business as well. So anyway, so the state recruited me, and now I help families within the state. I thought that would be an easier way, but
Silos. Just kidding.
Silos.
but it's still siloed.
Yep. Yeah.
Hi, I'm Jeff. I'm a nurse from primaries. I've been there for about 18 years, and 16 of them have been helping kids that are in shelter, so I'm not at the hospital. And so like a typical day will be like an undocumented family, 4 kids walk in and they need to get into school. And so they might have shot records, they might have a picture of a shot record or no shot records. And so by the time the provider's done kind of doing their thing, I'm jumping in to give them all the shots. So it's like, 7 shots each child. But these kids need other things too. They need referrals, screens, and other things. But by the end of that hour and a half, I'm just dead, and the family wants to leave. And I guess my question is, we have so many people in this room that have presented, and I haven't really even looked at the webpage for the registration. But are your contacts information available so that we can reach out to you later? I mean, I just feel like by the time the family leaves, there were referrals made, and I don't have any way of getting back to them. We have referral coordinators that kind of will try to do their thing, but I feel like, and the reason why I wanted to come to this conference is to know who to call. And then at the end of the conference, I feel like I'll just go back and just be like, wow, that was great, and guess I'll go give some more shots. So is that online? Do we have your contacts, or how can we?
I know, like I said, I will make sure that it's just a little slide presentation, but it has, again, like all those bullet points of what we do, the services that we provide, as well as our website and my contact information. But yeah, I don't mind. I'll make sure that it goes out to Tony to give out, to make sure that our organization can be reached.
Yeah, and I mean, all the people that have presented today, I just thought,
Yeah.
That'd be really.
I mean, so far I've heard, be brave, use your voice, organize, find allies, champions, professional Googlers, right? And to kind of dip into Erin's analogy a little bit too, Spider-Man says with great power comes great responsibility. Yes. And I think everybody in this room has great power. Everybody on this panel has great power. As a doctor, as a data analyst, as a person out in the community. And so how do you use that responsibly? And the families we work with, I used to tell that to the parents and the kids who are patients, like, you have great power here. You have a great responsibility to that as well. What does that mean to you? What does that look like to you? And it's worth thinking about for yourself. What does great power comes great responsibility mean to you, and how you utilize it?
And when a parent or a youth, they get frustrated and they don't know what to do and there's a barrier, connect them to somebody, a peer support, have them call the Utah Parent Center, reach out, start finding out what's out there and where can I use my voice to be able to impact the system to be better for me and those who come after me. That's the responsibility part, right? That make the system better. But it also, I've just seen so many families become empowered and strengthened by the opportunity to share and to make the system better, to be partnered, to not be the person who's always looked at as the problem, but to be a partner in the solution. It's really powerful. It makes a big difference to those youth and families.
Yes.
they can do that.
There were two things, and you just mentioned it too, that really stood out for me today. And it was when Carrie said, you don't know what you don't know, but you can help someone, to understand new things. And very first thing this morning, Katie was mentioning a bit again about partnerships and building those partnerships, but being very intentional about it, and not just building those partnerships for those that speak up. I loved that she mentioned that sometimes it's the people that aren't going to speak up that will still need those services, and you're the one who's going to have to help them learn about that. Even just to give them a resource to send them on. But yeah, I think this has been such an amazing day. I wish that there were like 200 more professionals here at least.
Yeah.
Like, I feel like what you guys have learned today, which every single doctor, every single medical professional was getting at some point. It's been a really great day. I appreciate your time doing this for our families.
And I want to say to Stephanie, thank you for that. That's one of the things I've been contemplating recently is as I work with leadership around in my new role, that they have such a zoomed out view, right? I mean, it's just by virtue of the job that, the data, how do we organize the data? How do we put things here? And in my head, I'm like, but there's individual lives attached to those data points that affects those people. And how do you bridge that gap? And for you saying, come with these individual stories, present them. It matters, it's powerful, they listen, they reflect. It can start to initiate change. So yeah, thank you for that. That was good for me to hear. It's something for the past couple weeks I've been like, how do we put a story behind all the data? Yeah.
And I think too, one thing I have come to find when I'm working with people who have a lot more power than I do is that they do have, they're approached with data from all sides, they're approached with different kinds of things. But the thing that does make the most impact, and the thing that I've found that makes the most impact when I'm on the Hill or something like that, when I'm going to talk about gun violence, for example, the first thing I do is I actually share a story of a patient who's been impacted by gun violence, right? I have dozens of those stories, but I just kind of come in and say, hey, this is an actual experience of a child who is a constituent of yours, that this is their story. And this is how they're impacted and how their family is impacted, their community is impacted. Now let me tell you about the data, which is important, of course. But if you can lead with a story, that goes a long way, for sure.
And if I can just add the kind of human connection of stories, I think one of the systems that really hasn't been brought into the room very much today is social media, and the beauty and power and devastation of social media, and the stories that are happening on that platform, and honestly and truly how they're influencing research and systems and things like that. And so I'm not saying don't be a social media influencer, but I'm saying in addition to that, finding ways to connect with leaders directly, create that human connection, as opposed to that, I like the term artificial intimacy, right? Is really where I think we become distracted a little bit because of that world. And it's, there's amazing benefits to social media. I know that as a parent, right, of a kid with medical complexities, I have definitely found some great resources through social media, and it does not compare to being able to connect with people and the power of that face-to-face connection.
Yeah, I have the honor and privilege of being connected to Dr. Avondet's social media. And she is, you are a legit.
It's a little too spicy.
You're a policy. Her anger, you're a policy advocate. You educate, you promote. You've done lives about vaccine hesitancy. You are a true champion for the health of those kids, man. I mean, I've worked with many docs and residents at primaries who give me hope for the future of children's health, and you're one of them, honestly.
I love that. And again, I'm going to put the responsibility back on you. We are talking about policy and systems change on this panel, and that's coming up even just beyond November. Again, I am a constituent of a very specific representative, and he might not be on the board or on the same committee that our education bills are going through or that our Medicaid bills are going through. But your representative might. So you can share my story to your representative, and that's super impactful. It's super important. And then you take her data along with my story, and that's kind of how we get things to change. But yeah, Kurt Cullimore doesn't care about a lot of things, like that has to do with that if it's not economics. So, it's hard for me to do that sometimes, but everyone here has to represent everyone here to a certain degree. So yeah, please pay attention to, beyond November, what's going on in our state and those policies that are coming out of the Hill, So
We have a question over here.
Question and comment. I think, Erin, thank you so much. I mean, obviously, I feel you, girl, because I just joined the Voices Board a year ago, so did a lot of advocacy on the Hill. I wanted to, just puke sometimes. Yeah, exactly. I feel your anger. I feel your anger. And especially, like you were just saying, I mean, I just think, especially now and kind of with all of the negative rhetoric, and especially for our QT BIPOC communities and all of that, it's just crazy. But I guess one of the other things I was thinking of in that idea of systems change too, and I love the data geek out because I know data is the only thing that really drives stuff, right, to make change, is let's not forget that oftentimes our BIPOC community is not represented in that data. And so I say this just kind of throwing it out there, there are nonprofits out there that have that tether and connection to various cultural groups here. Again, because they're underinsured, they're uninsured, it's not going to show in the traditional data sets. They're not accessing healthcare. But let's not forget that if we're truly going to be humans to all humanity, we've got to really stretch that net large and wide so that we can make sure that we're truly representing everybody here in Utah.
I love
Yeah,
that.
and know that we're here to be partners on the community side with you and all of that.
I love that. Yeah.
Thank you.
I just want to build on that a little bit.
Yeah.
With the service that I'm the medical director for, I actually was supposed to be going to Orlando, but whoops, there's a hurricane, to present about my program on Sunday. But one of the things as I was looking through the data, specifically about language, I got all the data that was pulled directly from our EMR. And I was looking through it and I was like, this is 0% correct. This is not right. Thankfully, my service is small enough that we could do a manual review of who required interpretation. It's very simple. Who required interpretation, who has not. We went one by one, patient by patient. And it said that over 75% of our patients were English speaking. When I went back through, it was actually 68% were non-English, they preferred a different language, right? And so the data sources that we're pulling from are not right? And this is where we are trying to get as much data as possible is through our, these sources. And when we look at that data and we say, how can we improve this? That's a systems improvement that's going to improve actual lives, right? That's going to improve healthcare. And so if we can recognize where those gaps are, then we can actually improve the outcomes for our patients and also just the provision of care that we do every single day. Whether that's, hey, it turns out we need more interpreters. And here's how I know. It's because our patient population is showing us this, right? And we are not meeting their needs. And so I was kind of floored by it, but I was also but I'm not surprised that that's the way that the data came out once we actually did a review. So it's just something to, think about when you're data's showing this, but sometimes we have to really dig into that data and make sure that it is correct. Otherwise, we run the risk of really leaving people behind or leaving them out.
Yeah, thank you. Thank you to our panel.